What's this I hear that opioids are not as effective as ibuprofen and acetaminophen?
I don't want to say I told you so, but I told you so. So find out today on Medical History Mysteries.
Hey, everybody, welcome to Medical History Mysteries. And we are talking about the latest in opioid research. And I'm hearing that opioids are not as effective for pain control as that beautiful combination of acetaminophen and ibuprofen. Tell us about it.
So I'm going to tell you all about this research that was done in Rutgers University, a Rutgers Health study that involved 1,800 patients. So a fairly large size audience. And it was randomized. So some of the patients received a combination of ibuprofen and acetaminophen, and some of the patients received hydrocodone and acetaminophen. And the results were what I would expect. So the results said those people who took the ibuprofen and acetaminophen combination said even through day one and day two, they had better pain relief than the patients who just took the hydrocodone and acetaminophen combination. And in no time was the hydrocodone considered better than the ibuprofen and acetaminophen combination. So we've been saying this for years, Pam. It's nothing new, but the more studies that come forward that indicate this is the truth, the more that we can validate that the combination of ibuprofen and acetaminophen really do the job better than an opioid, the better. Now, you know me, you've heard me lecture. A lot of people in this audience have heard me say that that doesn't mean that opioids don't have a place in dentistry. They do. They're really considered an escape strategy, a way out of significant pain. But opioids will never treat pain. They will just postpone it. That's okay, because sometimes that's all we need is some time for the ibuprofen and acetaminophen combination to do its job. So we never prescribe an opioid in place of. We always prescribe it in addition to the ibuprofen and acetaminophen combination.
You got to be careful, though, with the amount of acetaminophen that you're taking if you're going to double up.
Certainly true. And this is why I often say you've got to take in all forms of acetaminophen that the patient can take. This is why you take that medical history, right? So realize that in the same day, you're taking the acetaminophen combination with the ibuprofen and maybe an additional dose of acetaminophen in the opioid. You might also be using NyQuil, Dayquil, Tylenol, cold and sinus, Theraflu, Excedrin. And all of those contain acetaminophen too. And you could easily go beyond the 3,000 milligrams per day dose that's offered by the manufacturer of Tylenol and the 4,000 milligram per day dose that's offered by the FDA as maximum daily doses. So as the clinician, we're prescribing, it's not our job to watch how much acetaminophen the patient takes. Well, it is. That's the point. That's why you take the medical history and you warn the patient, look, I'm going to be prescribing you 500 milligrams of acetaminophen. I'm also going to be prescribing an opioid that contains 325 milligrams of acetaminophen or 300 milligrams of acetaminophen. You add those together, you've got to be careful. You've got to stay under the 3,000 milligram dose for the day. Please don't take all of these other things I've seen listed on your medical history in the same 24-hour period, because that can easily lead to Tylenol toxicity and potentially liver toxicity. Just warning you in advance. Stay clear of the other things you're using for now. Just follow this regimen. It's 3 days, man. Not a long time to ask them to abstain from these other things, but other issues apply here as well. If you know they drink alcohol on a regular basis, if you know they smoke cigarettes, alcohol, cigarette smoke can speed up the metabolism of Tylenol into bad things for your liver. We don't want that either. So again, we're asking them to abstain. We're asking them to stick to the regimen and realize that if they say, no, 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 I want the good stuff, I want the opioid because I know that's going to work. This is why I say you want to prescribe the ibuprofen and acetaminophen combination, that's fine. And we all know it works better. That's a hard sell to your patients sometimes. So don't give in. But if you really feel like, yeah, this patient's right, they're really going to be suffering tonight, then don't not prescribe the opioid. Then say, okay, I am going to prescribe the opioid. It's going to be 6 tablets. Take them only when you need them for severe pain. And that way you've really not only garnered safety for the patient, you've garnered their confidence and their loyalty. hey, that doc really listened to me, and he or she was really aware of my fear of pain, that person's going to follow you forever.
Don't forget, though, you got to check the prescription monitoring program for your state.
Can't say it enough. You've got to be an expert in that patient. It's got to be checking the medical history. It's got to be checking the prescription drug monitoring program in your state. You got to find out what other opioids are being prescribed for that patient by what other prescribers. Because again, let's say to your point from before, the patient's going to say, okay, I won't take any of the NyQuil, the DayQuil. But then when you look at the prescription monitoring program, you find out, oh, you're taking another prescription opioid from another prescriber, which also contains acetaminophen and also contains an opioid. Maybe prescribing an opioid to you is not the best idea in this situation. Do you have to have that conversation? Maybe not. Maybe you look at the database and say, you know what, I'm not even going to mention the opioid. But if they mention it, then you can tell them, hey, I looked at the database. I see you're on these other medications. It's probably not a good idea. I don't want you to double up. And that, again, makes me feel as the patient, oh wow, they really cared. They actually looked me up in the database and actually, are trying to save me from hazards. I like this office. I like these people. They are really looking out for my best interests. You could look at it the other way and say, what are you trying to do? Spy on me? I'm not saying patients don't think that, but I'm saying I'd rather be on the right side and defend myself that way than the wrong side and later have to say, well, I didn't check the database. I didn't think to look there.
So let's go back to the study. Because obviously we see patients with different levels of pain. And I would imagine that that study with 1,800 subjects in it, I would imagine the pain is maybe all over the gamut, maybe some mild pain, moderate, and maybe some severe pain involved there. And obviously, pain's a funny one because it's your perception of pain. So my 6 might be your 2, I mean, we don't know. And so would you say that if we're going to generalize, let's generalize for dental pain, your real go-to should be ibuprofen and acetaminophen, unless you find a specific reason that you need to kick it off with some opioids, right?
Well, right, and that's one thing about this study that I like was the fact that again they use what we consider to be the hallmark of dental pain that requires management, which was wisdom tooth extraction. Okay, so I'm always looking at that as the barometer. Like, can you tell me, do you have excessive pain from a wisdom tooth extraction? Okay, then you may need an opioid. But for some minor procedures, usually ibuprofen and acetaminophen is enough. So if you're going to have that conversation with the patient, let's put it in perspective as, okay, you and I both know what you had done today. You really feel you need an opioid for this? Tell me why. What's your position on this? Well, I don't like pain at all. Okay, well, here, this ibuprofen and acetaminophen combination will do very well. But if they had a third molar extraction, it might be a different conversation. Like, hey, this is going to be significant. You're going to have significant swelling, significant discomfort, and ask. I could prescribe you an opioid. What do you think? Knowing before you even had that question out of your lips, you've checked the database, you've checked their medical history, you know enough about them to ask that question. I think when you ask them and you give them the option, there is a fair number of people who would say, "Nah, I probably don't need it. I'm okay, doc." But the fact that you offered it was enough. If you offer and they say, yeah, I think I'm going to take you up on that, doc, that's fine too. But again, you've garnered that confidence. Like, wow, that's really cared. Doc actually asked me about what I want to do. So I don't think there's a wrong way to approach this once you've armed yourself with the information and once you're talking to the patient about being realistic about their expectations for pain control. What I mentioned, using alcohol, smoking cigarettes, if they're in their medical history, you're darn right I would. I would tell them all about it because you and I both know using alcohol, using tobacco, when you're recovering from an oral surgery or something like that, not the best idea. So those are the things you do in that conversation to not only garner confidence, but also make sure you're doing the right thing for the patient.
I think that's terrific. Having an open conversation is the best way to go. And I think for those of us that maybe prescribe opioids on a regular basis and maybe aren't as confident prescribing acetaminophen and ibuprofen, maybe this study will give you a little push to know that this is a really legitimate alternative. And this is something that we should probably consider as a first line.
And there's no cookie cutter approach. There's no one size fits all. I know when you look at a study that's been published, they say, well, I used 400 milligrams of ibuprofen and 500 milligrams of acetaminophen. And I can find many studies that say the opposite, different combinations. what's right for this patient is what you think is right for this patient. I know plenty of clinicians that go with the 600 milligrams of ibuprofen and the 325 milligrams of acetaminophen instead. What's the right way? I get this at my webinars and seminars all the time. Tom, just tell me the dose. And my answer is there is no dose. It's whatever's right for that patient based on their medical history. Have they had issues with their liver? Do they consume alcohol? Have they had issues with ibuprofen in the past? Are they taking Coumadin? Are they taking another anticoagulant? I can't tell you all that because I'm not intimately involved in that patient's care. You are. So you take all that information into consideration. If you ask the ADA in their most recent guidelines, they said what? 400 milligrams of ibuprofen or 440 milligrams of naproxen plus 500 milligrams of acetaminophen if you think it's required. That's a generic dose for a generic patient. You take that and you adapt it to the patient. You are taking that information and fine-tuning it for the patient. Now, keep in mind, that's for adults. For kids, for aliens, you got to do the dose calculation yourself. The ADA doesn't even give you doses. So that's why, again, it's always about taking that treatment plan and tweaking it for that individual patient.
Now, I already know I can like feel it through the screen. People are going to be like, no, I want more. I have to hear more. I need to hear more about this Coumadin thing and the liver and the this and the that. Don't worry. We've talked about this before. So if you go and look back for past medical history mysteries, we have talked about ibuprofen and acetaminophen. I don't even know how many times. So it's certainly there. But if you have a specific question that you feel like we haven't quite addressed for you and you want us to do a deeper dive on it, just send me an email or send me a DM on Instagram. So happy to accommodate if we didn't already answer your question on a previous medical history mystery. So great advice. We're going to put a link to this study so you can check it out yourself. And we will see you all next week.
Take care, everybody.